Healthcare is a field that is constantly changing, and it requires the participants to constantly change. I'm not sure if we have any physicians here, but if not, you already know that they don't like change. They are highly resistant to change. But if you want to continue to be financially viable, you will have to adopt change. So, documentation, I can tell you that in my audits that I do, documentation is horrible. In most cases, it does not even remotely support what was built. And yes, I am one of those CDI folks that are constantly on physicians, but it is going to be one of the determining factors about how successful you are going forward. The documentation's purpose is really to tell the patient's story. What is going on with this patient, not only in the past, but from this day forward. So we are very fast approaching the end of time when that 1 year flexibility was offered by Medicare. So if you haven't done much to step up, you don't have much longer to do so. We are already seeing denials, particularly some of the private payers, where the billing is lacking in specificity. And just so you can be clear, if you don't already know, many years ago I had a chance to go down into Florida and do some training with the Florida Medicare contractors, and they taught us how they established these edits to identify suspicious billing patterns. And I have never forgot that training, and it still stays with me today. But when your claim goes through the edits, for the most part it is an automated system until it hits a series of edits where something seems to be very questionable. And at that point the automation pauses, and then they will look, someone will take a look at whether or not they can pass the claim. Do they need to request medical records? Do they need to just reject it? Now, when they request your medical record, at that point, it is all about the documentation. It doesn't matter what you've reported on the claim. Well, it may matter if it's very distorted, but your documentation is going to be the key that is going to get you paid or not, or possibly move you into some kind of investigative mode. So document as if you expect a payer review, because that is going to increase going forward, that more and more reviews are going to be requested. All right, so the documentation must be complete and it must be legible. It must clearly indicate the reason for this encounter with some relevant history, an exam, findings, any prior test results, and your impression for going forward. Now, unless you're talking about multiple trauma, there's rarely a need to examine that patient from head to toe. But yet we see that a lot. And payers will toss out a lot of that because it's just not relevant to the reason the patient is being seen today. Now, let me pause for a minute. These EHR systems, whether you like yours or not, they will get you into all sorts of problems if you're not very careful. This click, 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 clicking business on all these little bullet points, that is not going to help you if you get an audit. You have to keep in mind that this vendor does not pay your claim. They have no influence on a payer's decision, and they will have no financial responsibility if you get targeted for investigation. I have worked 2 audit cases where the providers tried to claim that my vendor said I could do that. And the U.S. attorney said, and I don't care. Your billing is not compliant. Who you bought your system from is irrelevant to us. Neither of those had a good outcome. One of those groups is currently under a corporate integrity agreement. And the other one, the physician was actually arrested in his office and he's been indicted for fraud. So that is not going to hold up as an argument of something about your EHR system. It is still the responsibility of the billing provider to make certain that the claim has relevance to the reason they are seeing the patient. All right, so the diagnosis coding is where we see so many problems. It is severely lacking in specificity. You need to forget, for the most part, any unspecified code. They really don't have a place in I-10 code set. But did you know that a lot of payers, if you send through an unspecified code, to them that translates to I don't know? That's exactly the message they get from it is I don't know. So a lot of the encounter forms that I see in physician practices, everything on there is unspecified. So what are you saying to me? Are you saying that you don't know anything about any of your patients? Because that is the message that comes through to the payer. Now, here's an example about whether or not this clicking business has relevance. This patient is presenting for a wrist sprain. They do have COPD and they do have type 2 diabetes. But do either of those conditions have any relevance at all to the encounter for the wrist sprain? Probably not. So if a lot of these systems are set up in a fashion that it is going to count the number of clicks and it is going to give you a suggested code level. But there's 2 major things that are wrong with that approach, and one is the things you click on, yes, they have that problem, but it's not relevant to today's encounter. And 2, the payer is not going to see it as being relevant. This particular encounter is probably not going to equate to higher than a 3. But I bet that system, counting those clicks, are going to suggest a 4. And the payer is not, when they initiate audit and investigative action, you're now on the defense. You can say, no, I'm not doing that. And they can say, yes, you are. We've got 8 months worth of claims to say you're doing it. So the argument when you have to sit down with a U.S. attorney is going to start off unpleasant and get worse. All right, so what should you show? You should show the progress, response to any treatments, and be clear about your diagnosis. That diagnosis code set is the driver for medical necessity of every service you bill. All right, so these are the key components. Now I'm going to slant this slightly towards evaluation and management for 2 reasons. One, every physician uses it, at least some. Internal medicine, primary care, those types of practices will use it very, very heavily. But most physicians do use it, at least some. And it is the code set that gets most physicians in trouble. Every audit I have done, and I've done probably at least 30 in the last 3 or 4 years, somehow evaluation and management was part of that. All right. You need to be clear. Remember that this is telling the story about the patient. Now, there are some avenues by which you can have a little bit of leeway, particularly in the area of emergency medicine. But the three primary components for evaluation and management are the history, exam, medical decision making. On some select cases, it can be time. If you have a patient that comes into the ED and they are not responsive, they are under the influence of some type of substance, they are otherwise impaired, you may not be able to get a significant history, maybe none at all. I actually started in this business in '76, and I worked for a very large hospital system in the emergency department, and it is very common to have patients coming in that you cannot get reliable information from. Also, you may see this in the pediatric arena, particularly where there's suspected child abuse. It is very hard to get reliable information from a 2-year-old, particularly if the parent is an alleged perpetrator and is in custody. So they may have to rely solely on what they can get from law enforcement, DFACS, those types of government agencies. If there's a reason that the history cannot be obtained, that should be clearly stated by the provider as to why. All right. Now, the established patients where you count 2 of the 3 components. The history is the component that falls by the wayside. The heaviest weight, and by far the heaviest weight, is given to the medical decision making, with an exam that is relative to the reason the patient is here. So I do read the history because I sometimes find information there that can play a part in the medical decision making, but it is not the component that I count. It is possible, and I've seen many physicians do it, write practically a book about the history. They had this 15 years ago. Well, is it relevant today? Well, then why are we talking about it today? It's kind of the position the payer is going to take. Several things you need to know, though, about this. If you're making no change in the management, none whatsoever, many payers will default to a level 2, and you will have to defend against that. Why is this higher than a level 2 when I've made no change from the previous visit? Now, if you've got some decent documentation, you may be able to argue that to a level 3, but that will be what it equates to, is trying to defend against what you have billed to a payer. I see the physicians do this all the time, and I have coached many of them about it. If at the end of that note they say, patient is doing well, return in 4 months, 6 months, there's no payer out there that's going to allow you a level 5 and probably not a 4, because you have just said that this patient is doing well and that you don't need to see them for several months. So if they are truly a 5 or even a 4, don't you need to see them before months have passed? And that will get them nearly every time. The payer is going to say, you just said this patient's doing well. Doing well in what context? If they were nearly dead 2 days ago and they're still alive, they may be doing well based upon where they were 2 days ago, but still you would be seeing them before months have passed. So that statement will do you in every time. Physicians have a tendency to write it and not even think. All right. It will be a red flag to a payer. Now, I have a good friend that is an investigator for one of the Blues, and she tells me not long ago that sometimes they get claims in the door that are so suspicious for fraud, they don't even handle it internally. Those go immediately to law enforcement. So you have to be mindful about how payers are going to deal with your claims. All right. Any abnormal findings should be clearly documented about why is it abnormal. This is one of the things that us CDI folks have to query about a great deal is we see abnormal lab results, not outside the norm by 1 or 2 points, but significantly outside the norm. And the physician has made no connection to any clinical relevance. And we have to query. So, for example, if this patient's glucose is 325 and the physician has made no relevance to them having hypoglycemia or any level of diabetes, we would have to query about the clinical significance of that elevated reading, significantly so on the glucose. All right. If it is negative or it is normal, then that is typically sufficient. But if it is abnormal in some way, we would have to query. All right, the medical decision making is going to be the highest weighted component of the evaluation and management. Here is where people get misled about this. In the CPT book, it simply gives you these 3 components. It doesn't tell you how you get to that. There's actually 3 subcomponents to the history and 3 subcomponents to the medical decision making. And the standard in the industry are those audit tools that were developed many years ago by the Marshfield Clinic. I use them on every audit I do, so do payers, and it is rare that I get a different result than the payer. Often what I get is that we believe this provider is overbilling by 2 levels. And yes, they say they have submitted all these 4s and 5s. We think they're 2s and 3s is our position based on the documentation. I get the same thing the payer does. It is very exceptional that I would get something different, and usually if I do, I've got a good argument as to why. All right, so these are the 3 subcomponents to the medical decision making. How many things are you needing to manage? Now, what you want to keep in mind, and I put this out there to a lot of physicians, is the MEAT acronym. This stands for Monitor, Evaluate, Assess, or Treat. Are you needing to do one of those things based on something the patient has presented with today? If your answer is no, then probably the payer's not going to give you credit for it. So how many things are you needing to manage? Now, are they getting worse? Are they stable? Is it a new problem? What about these things that you are needing to manage? And how much data do you need to review? That means any kind of diagnostic testing. Do you need to speak to another provider about something in this patient's history? How much data do you need to review? And then what is their risk going forward? The risk means from today in the future. It is not from today going backward. From today in the future, what is this patient's risk for mortality or morbidity? I have seen 5 bill for pharyngitis. Are you telling me this patient's going to die real soon from pharyngitis? Because that's the message that the payer gets, and they know that is extremely distorted reporting. All right. In your management options, we just spoke about this. If this is a new problem, are you going to do a workup, yes or no? Meaning you are going to arrange some diagnostic testing. You either do it in the office or you send the patient to an external site to have the workup done. So are you going to do some workups? Now, make sure that you're clear about this. Don't just click on something. Explain yourself, because if you either do it now, you'll have to do it with a payer once they tag you for an audit. You've stated in the record that you've reviewed another physician's records, that you have reviewed some studies already done, that you spoke at length with a family member about a patient's condition. Now, if the patient is responsive and able to speak with some coherence about their history, then it may not be that you would get into it with a family member, but if they are not, then you probably have to get quite a bit of your information from a family member, or speak to a family member about where you go from here. If you're going to coordinate something with another physician, who is that physician and what are you going to coordinate with them? All right, so for the data you're going to review, labs, you're going to order labs or you're going to review labs. The same thing with any type of imaging. Are you going to order it or you're going to review it? Are you going to look at something that is non-lab, non-imaging, such as EKGs, echo studies, those kinds of things that don't fall specifically under one of those categories? Do you need to go and speak to that radiologist or speak to that pathologist about the findings? Do you need to have some records sent to you, something about this patient's history? Now, this is one that you need to be really careful about. This has to do with not just looking at a report. That you actually looked at the imaging yourself and made some conclusion based upon what you see. Now, another area that causes a lot of queries, let's say that the radiologist said this appears to be aspiration pneumonia. The managing physician simply says pneumonia. So we don't have a consensus about the specifics of the pneumonia. Is it aspiration? Is it community acquired? Is it bacterial? What is it? So we would have to query the managing physician. Are you in agreement that this is aspiration pneumonia or no? And if they still do not meet some type of consensus, then we have to go with whatever the managing physician has stated. They are the manager of that patient. All right, what is your risk? Now, this part is not only the risk now, but in the future, based on the presenting problems. To have a high risk in one category is not the end of the story, because there are multiple components here. Now, these tables of risk I have put in there, I actually got them from CMS. But these things that you see on the screen would be considered a minimal risk by itself. Now, if you're doing things for multiple categories, then you would count the highest level one. These would be considered a low risk. This is based on those standard audit tools developed by the Marshfield Clinic. So if you're going to send this patient for physical occupational therapy, PAYA doesn't see that as being high risk. It's low, based on the Marshfield Clinic. These are moderate. This is one that we use a lot. If you managing prescription drugs. Now, I've had a lot of discussions with physicians where a patient will come in and say, will you write this down on the script because my pharmacist, my plan won't cover it. It doesn't matter if you write it on a paper bag. The idea is, can they get this drug from a pharmacist without a prescription? If the answer is yes, they can send them to buy it over the counter, then it doesn't qualify as prescription drugs. If the answer is no, they must have a script presented to a pharmacist in order to get that, then it would qualify for prescription drug management. But remember that if you've had them on this same dosage and same meds for quite some time, and they come in today and you make no change in the strength and the dosage frequency, then the PAYA is probably going to default to a 2, that you've made no change in the management. Now, if you say that this is a high-level patient, it's got to meet one of these criteria. And this is only one of the components. So they've got evidence of brain trauma, stroke symptoms, MS symptoms. I have asked several physicians, if you have them on a drug that requires some type of intense monitoring, such as chemotherapy or some of those other infusible drugs, then I would like for you to state that this requires intense monitoring as long as you have them on this drug. Now, that you can count a decision to not resuscitate, because now the management options are going to be very different than they would be if you hadn't issued the DNR on this patient. They having major surgery with some very significant risk, then that could fall into this category. But you can see that we're talking about really major issues with these patients to equate to a high level. All right, what are red flags to payers? Well, one of them is consistently billing the same thing every patient you've got. The I-10 code set is so specific that it would be rare that you would have a lot of patients with exactly the same diagnosis code. Now, if you bill a very generic diagnosis, but you select a high-level E&M, those edits at the payer are going to catch that because you don't have a match. Your diagnosis indicates that there's not much wrong with this patient, and yet you say that they are high level. All right, so let's look at this example. I actually audited this group not long ago. It's a pediatric practice. A child came in for its annual wellness visit. Within the documentation, the physician did mention that it has some developmental issues in one of the upper extremities. Only mentioned that. Mentioned then that the patient's parents may seek a second opinion. There were no diagnostic studies, there were no referrals to another provider, there was nothing done beyond mentioning the fact that they had these developmental deficiencies in that upper extremity and that the parents may seek a second opinion. That provider had billed not only the wellness visit, but also a level 5 E&M. No way that met it. She didn't even do anything about that problem, except to state that it's present. And she made no referral to anybody to investigate further about this problem the child has. So that was totally discounted. She only got credit for the wellness visit and nothing for the evaluation and management because she did nothing about it. All right, if you're using prolonged service codes, be very careful with that. I'm aware of an audit that took place a while back on a physician that everything she billed also had prolonged service codes on it. And they pulled in her records and could not find any justification for that. And one of the federal investigators went out to her office and told her that her billing does not support all of these repeat prolonged service codes, and why is she doing this? And she said, it's the only way I can get enough money to run my practice. Was that smart to say that to a federal investigator? So she is under a corporate integrity agreement. But remember that they are always watching. In some way, they are always watching. Now, they do compare. If you've just recently got a comparative billing report, pay close attention to that because that information is going to indicate to you what you may be watched for if they say that you stand out against your peers for this billing pattern, they've already captured that in the edits. That is how you got the comparative billing report. All right, with time, there's not really a good reason to use time as your primary driver if you can meet the other three standard components. Time can be used where this is mostly a counseling session where you would not be doing an exam, not likely. I used to audit a group on a regular basis they only dealt in child abuse. It is very difficult, and those are very lengthy encounters, and often those providers were giving court testimony about whether or not the child should be removed from the home. And because they are so very lengthy, they would document the time at the bottom of the note and state that this is a 2-year-old, that there's been allegations of sexual abuse, and they are using a social worker and a doll or whatever other kinds of mechanisms that might be available to use. And so they did, but it does require them to document time in minutes. Minutes is the deciding factor. All right. So don't use time as routine. Only when there is going to be problems with meeting the three standard components. All right. The wellness encounters, annual physicals, where you're going to make reference to many different things. If you're going to be on a separate office visit, it has to be over and above, obviously so, what you would address on the wellness visit. Now, if you detect a problem that now requires you to do extra management, let's say that you've detected on this wellness visit that this patient has hypertension and hyperlipidemia and so on, and now you've got to initiate some treatment for that, put them on some type of medication, then you might be able to justify additional office visits. All right, so both can be billed if you have clearly met problems that are outside the expectations of the wellness visit, and you need to be specific about it. Now, there's been a lot in the media in recent time about these overprescribing of controlled substances, and the CDC has got some literature out there about it and so on. And yes, patients can be very demanding about what they want you to do for them. But still, for the payer's position, it has to meet the medical necessity based on what you've documented. In fact, I have just completed an audit that I'm highly suspicious that provider is running a pill mill. There's just too many suspicious things about that whole idea. So it was indicated to me that there were certain things I needed to look for, and I have detected that. All right. If you have identified a problem that is going to need additional management, then you need to put that in your diagnosis codes. Now, a lot of times when I'm talking to physicians, they'll say, well, I know my patients. I don't need to write all that down. And yes, that may be true, but the payer does not know your patient. They are going solely on what you've documented. The major payers process several million claims a year. There is no way they can know details about your patient. So the documentation is going to be required. Now, while we're on that subject, these patients with these very high deductibles have brought about some new things that have to be addressed. And one is that they are going to scrutinize what you do closer than they ever have before. They want explanations. What are you going to do? How am I going to benefit from it? And what is it going to cost? And you're going to have to justify that because patients are very educated these days about their health care. I had told you earlier that I travel all over the country, and I had a seatmate on a recent flight that told me that she and her husband own a small business. And they have recently taken out a policy that has a $20,000 deductible. That means unless they have a catastrophic event, everything will be self-pay. And you will have to manage them as if it is a self-pay patient. So that has brought about a lot of new things in regards to revenue management. Also, if you have a patient that is claiming medical mismanagement, the first thing they want to do is run to an attorney. And the attorney then, if they take the case, is going to hire whoever they need to develop the case. That means nurses, therapists, coders, billers, sometimes independent physicians that are going to go through these records and identify areas of weakness. And that is what the attorney is going to use as the driver against the physician. I have been hired by an attorney that said, take these records and find a way for me to discredit that witness. It took me 10 minutes, if even that, to find the loophole that will be used to discredit that witness. So it is not only about getting payment from payers, it is about defending yourself should a patient claim medical mismanagement. If the documentation is really vague and ambiguous, it is difficult to defend against a medical mismanagement claim because those patients claiming medical mismanagement, it's easy to get the sympathy of a jury by claiming that I was mismanaged and I've got all these problems as a result of it and it's costed me this and this and this, and it is easy often for them to get the sympathy of a jury. And when you have a very aggressive attorney that already knows about the weakness in this documentation because they've hired people to identify that, then it is difficult to defend against that, and the patient is probably going to get some money. A diagnosis needs to be stated somehow by the physician. Now, yes, you may be waiting on diagnostic test results. But I can tell you that from a quick turnaround money-wise, it is easier or quicker usually to get your money if you wait to bill until you get those test results. And you bill based upon the result and not the symptom. Because let's say you send something through today and you have a very generic diagnosis code on there because you don't have the test results yet. So you bill today, and the payer feels that may not meet medical necessities, so they request your record. If you'd have waited 3 days or so till you had the test result and billed with the result, then they may not have needed to request your record. But every time they request your record, it is going to delay your money by 30, 60, 90 days or longer, or they may not pay you at all. And you might 6 months later still be trying to argue about whether or not they're going to pay you. All right, so look at your staff that is doing your billing and coding, and how strong are they? I've been in a practice where they have rebilled the same claim 8 times and never made any change to the first denial. And I have said, why are you doing this? And they said, we don't know how. So what is wrong with that picture that no one here has the slightest idea how to deal with problem claims? This rebilling without attempting to fix anything is going to be another red flag to the payer. All right, now I had already mentioned earlier about these EHR systems. Be mindful that if you're audited, you will be audited by the code book, not by an EHR system. The coding standards that are published in the code book itself is going to be what you're going to be audited by. If that particular payer has issued some guidance about a certain service that if you bill us for this, we want it done in this fashion, then yes, that would be part of what you would use. But I'm told in advance, what am I to use? Am I to go strictly by the guidance in the book? Is there some guidance issued by this payer that says if you bill us for this, you must do it in a certain way? So be mindful that having data entry people that have absolutely no knowledge about coding guidelines and conventions, it's not going to help you if you get an audit. You will be audited by the book. One of the areas where I see a lot of problems with this is that certain types of reporting require certain sequencing of the codes. There's no mystery about this. The code book itself is very clear about this. If you bill this, you must sequence the codes in this fashion. If you don't sequence them like that, your claim is not going to go through the system edit smoothly at the payer. But when I do the audit, or my peers, we're going to audit based upon whether or not there's proper sequencing of the codes. So there's no mystery about it. The book is very clear. All right, I believe we've already covered this part. Okay, they also look at the type of specialty you're in. How likely is it that you would be seeing patients of this level? If you're in primary care, family practice, you will not be seeing many patients that would meet a 5 or a 4. Now, if I have such a case, and they are billing a 5 or a 4, I want to see, and I'm looking for it in those records, what are you doing about it today? Because that equates to the need to do something very quickly about this patient if they truly need me a 5 or maybe not a 4. So what are you doing today? Are you sending them to the ED? Are you sending them to another provider to manage a certain problem that's been discovered? But what are you doing about it today? Whereas if you're in some of the higher level specialties such as cardiovascular and neurosurgery, you wouldn't see a lot of low-level patients because their patients are more complex. But I have actually seen a hematologist oncology practice where one of their providers, everything she billed was a 1. Well, your patients don't equate to a 1. These are high-level patients. So not only is that costing the practice money, it is also making her stand out. All right, if you're using mid-levels, remember that a lot of the private payers do not recognize them as a billing provider. Therefore, the claim must go out under the physician's name and number, and that means the physician has to indicate presence in the office and that they are providing a reasonable oversight of this mid-level. If they do have a billing number, Medicare and Medicaid does allow it, then and they do the work, the claim should go out under their name and number. And the reimbursement is somewhere in the neighborhood of 85% range. So if you bill it under the physician's number, but the mid-level did all the work, then the payer deems that to be overpayment. And they will be looking at some recovery of funds. All right, what about templates? Well, some physicians like them, some don't. The ones that don't like them tend to say they force me to put information there that I don't feel is relevant. So whether you like them or you don't, and there's nothing to say you have to use them. In fact, one of my personal physicians won't use them. He said he doesn't trust them and he doesn't think he can defend against them if he should get some type of audit. So he still handwrites all his notes and the staff has to scan them into the EHR system. He said, I know I can defend my handwritten notes if I need to. I'm not sure about those templates. Now, if you're in a teaching arena such as Emory Grady, where you've got residents and fellows on site, the teaching physician has to show a proper oversight of that resident or fellow, and they also have to show that they are the manager final determiner of this patient's case. All right, so these are some of the problems that physicians have with those templates. Is it really necessary to examine the patient from head to toe unless you're talking about multiple trauma? Usually not. Is it necessary to mention context in every case? Probably not. If you come in with pharyngitis, under what context did you get it? That's usually about injuries of some sort where they're asking about context. All right. If you check that every system is negative, how does that fit? Have you found nothing that's a positive finding? So you have to be mindful that who is paying your claim? It is the payer that is paying your claim. And you have to comply with anything they have put out there. Be mindful that my vendor said I can do it. It will not hold up if you get into an investigation. Now, unless your contract with that vendor says that they are going to be financially liable to you in some manner, should you get audited, the payer will not hold them financially responsible. It is the billing provider that is the one that is held responsible. However, I do know somebody that she's been to a number of my workshops. She's up in one of the northeastern states, owns a billing service, and she has new billing software, and she put it in her contract with that vendor that if my company fails an audit because of your system, you owe me and I'm going after you. And that is in her contract with them. And I asked her, did they sign that willingly? And she said no, but they knew they wouldn't make the sale if they didn't agree to it, because you're going to share in my damages I have to pay if I get audited based on your system. All right, copy-paste is another one that we see. It can tell you as an auditor, it's easy to tell it. They're doing copy-paste because the case gets very, very distorted. But each case should have a standalone note. What is the situation with this patient today? Now here's one that I found. Patient come in, this is an ENT physician, and he begins his note by saying, the patient is 30 days post-op TNA. Okay, that sounds pretty clear. But further on down in the exam portion, he says, today the tonsils are red and swollen. Imagine that. You took them out, you say 30 days ago, but they are red and swollen today. So clearly he's done copy-paste from a previous visit, and now this encounter has become very distorted. He didn't notice it till I said something to him about it. Did you really do that surgery 30 days ago or not? Because you say today that they're red and swollen. So this is the kind of result you get with this copy-paste. All right. The payer is going to notice that. If they have a reason to pull in these records, they are going to notice this distorted documentation, and they will be able to clearly determine that clone documentation is what was doing. All right. Now, you should do a sampling of your claims on a regular basis. Myself and my peers do this a great deal. We call it a risk assessment. The provider group just simply wants to know, is there anything in their document or anything about that billing process, coding process, that could be problematic in an audit? And when we will look at a sampling of claims, I usually do 25 per provider because it's hard to get a good picture with less than 25. And when we've identified some areas, if we do, that could be problematic in an audit, then we give them a lot of feedback that you probably need to really look at this and maybe handle this a little bit differently. and you can develop some kind of a plan. So it's desirable to do that on a regular basis. What I usually do is start with the 25. If they are looking pretty good, then I may only do 10 the next time. But if they are not looking good, then I stay with the 25 until we have gotten it back on track. All right, so that is a very cost-effective way to know whether or not you might get some type of investigation and be able to defend against it. All right, make sure that you do internal training. If you get a request from a payer to send records and you don't do that, then they deem that to be a red flag, and they probably won't pay those claims. In my early days as an auditor, I worked a case out of one of the upper Midwestern states where that provider group had sued their billing service for causing them multiple claims problems, and they won that case because that billing service, they were using modifiers that I have never seen before with no explanation about what this is all about. So if you don't be proactive, then you may find yourself having to defend against some type of payer audit. So that's the extent of what I was going to cover today. Do you have any questions?
When you get a request for records, what are the red flags for the ones that are routine and the ones that are not routine? Can you tell the difference?
Pretty much, yes. Based on their presenting complaint. Have you already been treating them for that before? Is this a new problem? If it's a new problem, are you doing workups? Are you going to request a consultation? What are you going to do about it? So yes, to some degree. Well, usually on the request, you can, if they don't say so, you can kind of get a feel based on the records they are requesting. What are they looking at? Exactly what are they looking at? Sometimes they do not a provider target, but they do a service target. Where if they have seen, let's say that in recent time, they have seen a huge increase when providers in this area submitting claims for MRI of the brain. They're going to want to know why. Why is it all of a sudden that all these people are requesting this service? So that might not be against the provider, but it could be against the service. But look at the claims they are asking. Are they telling you that they want you to define what's routine based on what's not? Well, if the levels you're billing, does the patient have that level of acuity based on your diagnosis codes? If not, then I would look at that very carefully. Because if you've used a low-level diagnosis code or something very generic that is lacking in specificity, then can you really equate that to a level 4? Probably questionable for a 4 and probably not for a 5. But now I don't know who is requesting your record or exactly the pattern of claims they're asking for. But look at your diagnosis based upon the level that you've submitted and see, does that make sense? Because that's really what it's all about. Does that make sense? Now, every payer does have a medical director, usually several. And I have advised a number of physicians that if you feel really strongly that you've met the medical necessity, then discuss it with that medical director, because they may see it a little bit differently after you've had this conversation with them, because it is two physicians that are discussing whether or not it meets that. The thing is that you can't use them as a customer service person. You would have to have some kind of something that is truly in a gray area. And I have used the medical director a couple of times in all my years, just a couple of times, but I did get a good response from them that showed me how to move forward after then. Yes?
Would you say that you've seen
Well, I think the underlying issue is that most of them are looking to take money back.
Aren't they limited to the number of records that they can request at a certain time?
The rack auditors, yes, but if it's not a rack, I'm not sure unless there's something in writing that talks about the number of records. But we all expect the rack auditors to begin to get more active now that we've passed the implementation date for I-10. In fact, I think all the audit activity will increase going forward. But in your contracts with your private payer, that is where you would address those kinds of questions. How far back can they go to recover money? And how many records would be reasonable for them to request at any one time? So if you don't have it in writing, they typically don't consider it worth discussing. Now, the payers are not the only ones that initiate audits. They are still the biggest player, but I have worked a number of cases that were initiated by a state medical board that had some reason to think there's unethical behaviors going on, and I have worked several whistleblowers that are very, very messy, and I've worked a couple lately that were actually initiated by the patient. So it can come from multiple sources. But the state medical boards tend to hire independent physicians to give an opinion about different matters. For example, one I worked was against two plastic surgeons that were trying to camouflage some cosmetic procedures as something that was a medical issue. And they hired an independent plastic surgeon that said this is nothing but cosmetic. I do it. That's the second most frequent service I do. This documentation is classic for that cosmetic procedure. So the state medical boards are the ones that typically will hire an independent physician. Anything else? All right, well, hold on to your money. It's getting more difficult going forward. And thank you for having me here.